Okay, so we'll get underway. Carpal tunnel syndrome, a very common condition, but that doesn't mean it doesn't require our full attention. There's a few tricky things about it. And the start this evening, I just want to ask everyone a quick question. In your opinion, what's the most complicated thing about carpal tunnel syndrome? There's a few things as far as I'm concerned. The presenting complaints can be obscure. The clinical examination can be difficult or ambiguous. Trying to work out how to test can be difficult, or coming up with a management plan. If you want to have a vote and let me know what you think is the most complicated element from your point of view. Yeah, and that's about what I would expect, a bit of a spread around there, people thinking both the obscure presentation and the management plan. So we're going to go over a few of those things today and try and clarify it. Carpal tunnel syndrome, although very common and although a very easy diagnosis, can create some problems. Everyone treats it because it's so common, and there can be this spread of expertise. The management, again, when there's a spread of expertise and everyone's treating it, the management can be varied and there can be diverse opinions. But if we don't get it right, complications can be significant. And what are we talking about? Well, here we go. Here's the carpal tunnel in this transverse section here with the flexor tendons passing underneath. And this nice diagram here shows the carpal tunnel open and the median nerve here, flexor tendons and the median nerve. And you see here very clearly as this retinaculum's been released, this waste in the nerve, you can see the compression point here. And we often see that at open carpal tunnel release, that the nerve's running along quite nice and happy. Then there's this clear cut-off compression point. Beyond it, you can see the nerve is thin and atrophic and unhealthy. So the nerve compression at this point in the carpal tunnel can cause quite a deal of damage, and that's what this is all about. What are these problems that carpal tunnel creates? Well, one is anatomical variation within the tunnel and with the nerve branches. There's always the debate about nerve conduction studies. So what do we do when someone's nerve conduction study negative but clinically positive? What are our conservative treatments? What are our techniques to decompress? How often does this come back? And then there's other things to do with other procedures, workers' compensation, which we'll mention, and difficult complications. The carpal tunnel is located here at the heel of the hand. We go down a layer deeper, past the palmar aponeurosis, we find the transverse carpal ligament or flexor retinaculum. And it's the structure that's running across the carpal tunnel as the median nerve passes underneath along with the flexor tendon. So this flexor retinaculum or transverse carpal ligament is the structure causing the compression. And the transverse carpal ligament runs between, on the ulnar side, the triquetrum and the hamate. This is the hook of the hamate here. And it runs across to the radial side to insert on the scaphoid and trapezium. So the carpal bones form the floor and the walls, and the roof of the carpal tunnel is the transverse ligament. Presenting symptoms can be diverse, and carpal tunnel is the great masquerader in hand surgery and hand pathology. But in general, the typical presentation will be pain and numbness in the median distribution, so those radial digits. Very commonly, they'll report that they're waking from sleep at night with numb hands. They will describe the whole hand, but that's the sensation they get. And then later, as it's more advanced, they'll get it during activity during the day, when the wrist is in provocative positions, full flexion, full extension. Weakness is a late finding, but can occur when severe. So you see the wasting in the thenar eminence. Symptoms, as I said, can seem to involve the whole hand. Now, this is the typical presentation. It can be quite typical. It can quite atypical. It can be a feeling of pressure or pain quite diffusely around the wrist. This diagrammatic representation shows us this classic median nerve distribution of the thumb and 2.5 digits. Investigations, well, really, from my perspective, it's nerve conduction studies all the way. And why? Well, nerve conductions provide qualification and quantification of the diagnosis. So they tell us for sure that it is median nerve pathology, that there's transmission delay across the carpal tunnel. And they give us a number. They give us a quantification of how severe that might be. And that's important when it comes to deciding what treatment pathway we might take, but also as a baseline measurement for our treatment later on. Even if we do surgery, we might want to come back later and have a look at those nerve conductions if we feel the recovery is slow or not what we're expecting. So nerve conductions are the gold standard. We may do an X-ray to reveal arthritis or bony spurs or post-traumatically around the carpal tunnel. Ultrasound may show some changes in the nerve, but arguably, if you've got nerve conductions and a classical clinical presentation, not particularly useful. And MRI, the same thing, not really useful unless we suspect there's a growth or a space-occupying lesion within the hand that we need to define. The nerve compression can be at various severities. Nerve injury is classified with the Sunderland classification, and Sunderland 1 is this type C here. So Sunderland 1 is a neuropraxia, and most carpal tunnels will fall into that grade 1 neuropraxia. When things get more severe on the nerve conductions and clinically, it's this type 2 axonomesis. What a word. Occasionally we can get, when there's scarification from ischemia, a type 3, but the other two classifications relate more to division. So we're looking mostly at this neuropraxia of the nerves where signalling is slightly delayed transiently, or up in this axonomesis where there's actually starting to be some destruction of nerve fibers. What causes it? Well, a lot of it is medical. It might be degenerative arthritis. It might be due to pre-existing conditions, diabetes, obesity. In pregnancy, we see it, third trimester. There is that retention of fluid. So anything that causes an increase in pressure within that tunnel, we saw that it's bound by the bones and that thick ligament. So it's a fixed space, pressure goes up, the softest thing gets squashed, and that's the nerve. It can be traumatic. Work-related can be repetitive activity or direct trauma, falling onto the heel of the hand or striking with the heel of the hand. It can also be with prolonged chronic joint posture. Another one that's quite common is vibration, particularly if unaccustomed. Another little question for you here, because this is a controversial part of carpal tunnel. Is carpal tunnel syndrome work-related? I'd be interested in your thoughts here. We're just going to poll everybody and see what you think, because this debate rages, and it doesn't matter how often we talk about it, it continually rages. I think we need one more vote. Come on, somebody vote and we'll get, well, it looks pretty unanimous. It looks unanimous, or not quite. So we've got most people saying it may be an aggravation of an underlying condition, and then a smattering of people saying it depends. And it depends is really the sneaky answer there, because like many things in medicine and surgery, it depends really is the answer. There is a link to repetitive tasks, and the analogy that I always think of is if you've never used tin snips to cut fencing wire and someone sends you out all day for 8 hours to cut fencing wire with tin snips, and at the end of the day your hand is numb, then it's clearly caused by that activity. You're not familiar with it. It's a highly repetitive, forceful activity. Your hand gets swollen, your median nerve gets squashed. So it can clearly be caused. Same thing with trauma. But it can be difficult for people. There's a little bit of an adversarial system. These workers get injured. There's some animosity about the cause of carpal tunnel. So that's where we need to have a very good history about what happened. What was the causative event? It's a bit different if people say, I've been working 20 years at data entry and just sometime over the last 2 years my hand went numb. It's not as convincing, but these very heavy, very repetitive tasks are much more convincing and reliable. In workers' compensation, the nerve conduction studies, in my opinion, are essential. We really need that documentation, that qualification and quantification of the diagnosis. But, as we've said here, in the Hand Society, 30% will release the carpal tunnel even if the nerve conductions are negative. So a nerve conduction study negative doesn't mean that the person doesn't have carpal tunnel. It just means we're probably in that Sunderland 1 where we've got a transient neuropraxia. So it gets worse, they get symptoms, and then the pressure's relieved, symptoms go away, nerve testing looks normal. So they have transient symptomatic carpal tunnel. So nerve conductions aren't the be-all and end-all, and the negative result just might require some more investigation. Return to work can be difficult in carpal tunnel and has to be carefully monitored. So once we've diagnosed it, we've got a classical history, we've diagnosed carpal tunnel, and I should have mentioned there the examination. We talked about potential wasting, we talked about numbness in the radial distribution, and the other thing to mention is that Tunnell sign, which is quite reliable. That's that percussion over the nerve. If you remember that picture where the nerve was normal diameter and then there was that waist, the percussion point would be just proximal to that, where the nerve's very angry and irritated. So percussion over there is the Tunnell sign, which will give them that electric shock feeling into the digits. So a positive Tunnell's, maybe some signs of wasting, a classical distribution, and then we've got our testing. Well, conservative treatment is going to be our strategy, particularly if it's minor and transient, or if there's a very reliable causative factor. So they describe a particular event or a course of events. We want to rest them from that and give them some conservative treatment. I mentioned this last week if you were at our webinar on flexor tendons, but biopsychosocial hand surgery is perhaps a nonsense term that I've made up, but I like to remind myself about it whenever I'm treating somebody. What it means is there's so many patient factors to take into consideration. So when we're considering treatment, particularly conservative treatment, but also surgery, we have to consider lots of the patient's position, their values, their likelihood to perform the treatment that we're giving them, the exercises, the splinting. We have to think about what external pressures there are, that adversarial situation at work, and we have to consider their psychological response. So different people will respond differently to injury. And that's all backed up with communication and a positive pathway to recovery. This is where our hand therapists come in very handy, with giving them a lot of positive reinforcement and very directed exercises and management. So resting and avoiding the aggravating activity is the key. We'll add in a night splint like this. It might be a custom-made thermoplastic. It might be this type of off-the-shelf. The main thing is it has structural support to keep the wrist neutral. In that neutral position, the carpal tunnel will be at its most open, and the flexed and extended positions are when the nerve will be compressed. So most people will sleep with their wrists in a flexed position, and that's when the nerve's going to be aggravated. So just adding a night splint can help them relieve those nocturnal symptoms and sleep at night. That, in conjunction with avoiding the aggravating activity, can be enough from time to time. But there's other ancillary things we can do, massage and ultrasound. Sometimes people find relief from acupuncture. Steroid injections occasionally are useful. If we have a very defined cause, then maybe we want to give them that little local anti-inflammatory effect to help settle it down towards recovery. I don't use them often in severe cases or moderate to severe, but very mild cases with a defined cause, I may use them. One of the circumstances to use them might be the nerve conduction study negative patient. So if they've got negative nerve conductions, but they've got symptoms, then a nice diagnostic test is a steroid injection to the carpal tunnel. If they report relief from symptoms, we have our diagnosis. And at the same time, it might be therapeutic. So steroid injection can be nice as a diagnostic and therapeutic strategy. The other group that's sometimes useful to use it on is the third trimester ladies that I spoke about before during pregnancy. We know that postpartum, they'll shed that extra fluid and their carpal tunnel will resolve. They probably don't want an operation in third trimester or immediately postpartum. So a steroid injection can just help them get across the line sometimes. So in that circumstance, it might be useful. There might be a role as well for medication, anti-inflammatory. So this is all short term. So this is our conservative strategy. Outside of that, we've got surgery. And then surgery takes various different forms depending on patient and surgeon preference. We have open carpal tunnel release, the old classic, the short scar open carpal tunnel, sometimes called keyhole, sometimes called minimal access. And then there is endoscopic. Last little question for the night, just to see what people are familiar with. What carpal tunnel release technique is most common in and around where you work? Endoscopic, the open, or the short scar open release? Couple more votes. Interesting. Okay, so the majority there are with the open, standard open technique, with a couple of people talking about the short scar access, and no votes for endoscopic, which to me is disappointing, but I'll talk to you in a minute about why. So the bottom line is, and really once we get to 2 to 3 months post-surgery, it doesn't matter what technique you had. The main thing is that this retinaculum is divided and the nerve has more space. That then stops the ischemia, allows reperfusion, the neurons can recover and transmission is restored. So the median nerve has more space once the ligament is released. Now, just as a point of interest, the ligament does reconstitute here in this greater format, so in this greater length. So if you come back for a recurrent 20 years later and you're coming in to do a release in an open technique, it will look like a completely normal retinaculum. So one of the things to note is that, and one of the things patients are often concerned about, is that you're dividing an anatomical structure, and what are the consequences of that? Well, it will restore itself there, and that's why we don't see bowstringing very often. Here's this picture again. This is a very extended open carpal tunnel release. We would not do anything like this, but it gives us a beautiful view of the nerve here. And as I said, this waist point where we see here this very, very profound crush point, and then this poor atrophic, pathetic looking nerve distally. So we do see this point, and it is often in this part of the retinaculum where the nerve is compressed. And you can see in a case like this that anything conservative is not going to resolve the issue. The endoscopic technique, I will confess, is my bias and my preference. So this type of technique where I use a 2-port, but you can use some surgeons will use a single port. And we insert a telescope to be able to look at the retinaculum from the inside out. In the other port goes our instruments and a blade. And you can see the blade here cutting through the ligament and releasing the retinaculum. Here we see the ports, although the camera's going in the other end, but this is the trocar that goes in proximally and out distally. And within there is the retinaculum, and it's divided. Now, what I like about it here is that these incision points are remote from this load-bearing area of the hand. Even a short scar access will be something like about there. So this creates these remote small port sites, about 1 centimetre each, And the recovery in the initial few weeks is faster, about 2 weeks faster to normal activity. As I said, 3 months, they're all the same. But to me, I feel my patients value a 2-week quicker recovery. So there is a steep learning curve on this technique. It has its hazards, but with experience, it's a good technique to get people fixed and up and running as fast as possible. In the rehabilitation, we need to closely monitor all carpal tunnel lesions, open, endoscopic, minimal access, everybody. We've got to keep a close eye on them because there are some things that can go wrong. The preferences in rehabilitation are as varied as the techniques and as varied as the surgeons, but I like to get them doing some gentle, limited active range of motion, even in the first 3 days within their bandages. And then that's increased between day 3 and 7. So by the end of the first week, they're making a full fist extension and flexion. I see them about that time, day 5 to 7, to check their progress. And if they're very stiff and not making a good fist, then they're off to therapy. That might be because they're very swollen. It might be because they're apprehensive or scared to get things moving. So we need to counsel them, as I said before. So different people will react differently physiologically and psychologically post-surgery. Most problems can be avoided if we spot them at day 5 to 7. Any longer than that, and it's starting to get difficult. The hand is extremely complicated, and there's a saying that the brain is in the hand and the hand is in the brain. The connection is profound, and we need to get things right here. So seeing them at about 5 to 7 days, if they're moving beautifully, they probably don't need much rehab other than paying attention to exercises. But if they're not, hand therapy. I aim for most people to be doing full activity by 4 to 6 weeks, even if they're a little uncomfortable. I've had boilermakers, tradesmen, carpenters back doing their full duties at 4 weeks. And full strength is a bit more delayed. 3 to 6 months, people will report a bit of loss of strength and some discomfort in the base of the hand. What can go wrong? Of course, hematoma and infection. Everybody gets pillar pain. And pillar pain is an ache across that base of the hand there. We think it's from the carpal bones, just relaxing a little bit, and it takes quite a few months to go away. The busier they are, the longer they'll have that pillar pain for. It's completely normal, and they just need to be counselled about it. Stiffness, as I said, can be a problem. Adherence of the nerves within the carpal tunnel, occasionally an issue, often helped with therapy and nerve gliding. Bowstringing is when we lose competence of the restraint on the flexor tendons and they bowstring across the wrist. It is fairly rare. It's difficult if it happens, but that brief period of immobilization tends to settle it down. And the last one we won't go into today, but if anyone's interested in a whole session on this, I'd be glad to talk about it at length. But RSD, reflex sympathetic dystrophy, sometimes called CRPS, I'm not even going to mention it anymore. It's a whole can of worms. Then there's these other things. Actually cutting the nerve during the surgery is the disaster. It does happen every now and then around the world. Every year there's a few bad scars, painful scars, cutting a cutaneous branch, so the palmar cutaneous branch, they'll end up with a numb patch in their palm. Cutting the motor branch to the thumb, so then they get wasting of their thumb muscles. That's a bit of a disaster. Incomplete decompression, so that's one where we want those nerve conductions so we can remeasure. Other injuries to the nerve, and then I said the tender scar or a nerve that sits subcutaneously once released and is very tender. So we have to watch out for all of these things and intervene if necessary. So it's not a completely benign procedure. There's a few things that can go wrong, but we just have to watch them very carefully in their recovery. And usually we can spot things early. So that's a very quick summary of carpal tunnel. That's all I wanted to mention tonight, because I know everyone's going to be busy and have other things to do. Most importantly now, are there any questions at all? We're live, so happy to answer any questions that you might have about carpal tunnel if you put them in the Q&A. Alternatively, I will post this. This will be going to YouTube, so you can refresh it later. You can ask me questions there, or you'll get an email from us after this, and you can direct some questions to me if you think of anything later. But if anyone's got any questions, now is the time. There's been nothing come through up till this point. We've got a question through. Do you have any comments on acute carpal tunnel syndrome? So acute carpal tunnel syndrome we were talking about, I mentioned in terms of acute trauma. So it's usually from a blow to the area or post-traumatic. So it can be fractures in the hand or forearm that cause swelling, or it can be direct trauma over the carpal tunnel. Now, the problem with it is that I think our question relates to is that if the onset is sudden and severe, so they get severe neurogenic pain and numbness in the median nerve distribution in the setting of trauma, that we may have to intervene and do an emergency carpal tunnel decompression. So my comment in relation to that would be that it is a clinical decision and it needs to be taken very seriously. It is probably the one circumstance where I wouldn't be doing nerve conduction studies. So if there is acute rapid onset of severe median nerve symptoms in the setting of trauma, then the suspicion is acute carpal tunnel syndrome and the treatment is emergency decompression. It's much better in those circumstances to decompress the nerve, even if it's resulting in a scar and it's resulting in a surgery. Relief will be curative and the damage will be minimized. But if you leave an acute carpal tunnel syndrome for the nerve to become ischemic, you can get up into those high Sunderland grade injuries, and that's unacceptable. So that's a long answer for that question, but yes, acute carpal tunnel syndrome is a hand surgery emergency, and surgery is the way to go based on clinical examination and history. So yeah, good question, that one. Any other questions at all? All right, well, we don't have anything at the moment. We've still got our full cohort here. Okay, well, look, we'll finish it up there. If anyone's got any further questions, please let me know. The main thing is do try and leave some feedback for me. We're trying to do these more often. There's my announcement that the NRL is back tonight. Please let me know what topics you'd like to hear, any guests you'd like me to have on to talk to about topics of interest, and importantly, what times you'd like these on. Is this time of night good for you? Any other time that might be better and more convenient? I'm happy to make it as convenient as possible. Also, you can go and check out our past webinars on flexor tendons and de Quervain's and nerve compression syndromes. Some of them are very advanced, some of them quite simple. So do check all of that out, spread the word around, and hopefully we see you here next time. All the details are there on the websites there for upcoming webinars, and we'll see you next week. So thanks for coming along. Hopefully you enjoyed all of that, and it's sort of solved a few problems with that very simple diagnosis. So thank you, everybody. Have a good night. We'll see you again soon.